Good morning, everyone. The name is Dr. Lenny Carroll. I'll be taking you through the pediatric surgical tumors. It's a review of the spectrum and the management outcomes at Kenyatta National Hospital. Just want to start by, I don't know if any of us actually knows cancers in our local language. Yeah. So, by way of introduction, it's been estimated that up to 400,000 children are actually diagnosed annually with cancers. That is globally. And most of these actually live in the low and the middle income countries. For the surgical tumors, the lymphomas, tinoblastomas, and the nephroblastomas actually are some of the tumors that constitute about 30% of these solid tumors. And for the case of this discussion, I'm going to limit it to Wilms tumor, which is also the most studied in the setting of Kenyatta National Hospital. So there's no true incidence of cancers actually in the African continent, but based on some incomplete cancer registries in sub-Saharan Africa, the incidence has been noted to be between 27.6 to about 308.2 per million. That is with data that is from those countries. And by about 2050, it's been projected that up to 50% of these of the global cancer burden in under 15 will be in African continent. And for the African story, the challenges of management of these childhood tumors range from inadequate healthcare budgets to about scarcity of diagnostic facilities and inconsistent drug supplies. And it's further compounded by the burden of communicable diseases that also contribute to the cancers and chronic malnutrition in our sector. So based on that, we set out to do a study, which was more of an audit, guided by the broad objective of to determine the spectrum and the management outcomes of pediatric surgical tumors at Kenyatta National Hospital. The specific objectives, we had the first one, to determine the clinical presentation, diagnosis of the most common of the surgical tumors at Kenyatta National Hospital. The second, to determine the mode of treatment of the pediatric surgical tumors at Kenyatta National Hospital. The third, to determine the complications, the length of hospital stay, and the post-discharge status of the pediatric patients with surgical tumors at Kenyatta National Hospital. For the methodology, we did a cross-sectional retrospective study in which we reviewed patients' files, that is between an 8-year period of 2015 to 2022. And these patients should have had a follow-up period of about 3 years within this period. We had the record department at Kenyatta as the main study setting, and the study population constituted those children less than 14 years who had undergone a form of pediatric surgical management. The source of the data, we mainly retrieved the data from the inpatient files, which were electronically retrieved, and then we had the manual retrieval of the records. And the information from these, we entered them into a preformed data collection sheet. And being an audit, we actually sought permission from the relevant authorities before conducting this study. For the results, we had a total of 135 records that were reviewed and analyzed, and the variables that we studied included the demographic characteristics. We had the clinical presentations, the diagnostic mortality, and the modes of treatment, and then the outcomes. For the outcome variables, we looked at mainly the length of hospital stay, the inpatient mortality, the postoperative complications, that is the immediate postoperative complication, and then the follow-up status of the patients, which was either you're stable on follow-up or you're either lost to follow-up within the time period. Still, this is just a representation of the results. The most common of these were nephroblastoma, which were common in up to 98 of our patients, that is contributing 72.6%, and then the sacrococcygeal teratomas, and then other less common tumors were the neuroblastomas, the hepatoblastoma, and the pheochromocytoma. Now, looking specifically at the Wilms tumors, we've already noticed it was the most common, And the peak incidence was about, the peak range at presentation was about 14 years, less than 4 years. And the male to female ratio, it was more predominant in the males. That is a ratio of 1.1 to 1 as demonstrated there. And most of our patients that we receive at Kenyatta were actually referrals from the surrounding areas, that is the catchment area, contributing to the Nairobi Population Cancer Registry, that is within Kiambu, Nairobi, Kajiado, and the Machakos counties, as demonstrated in that. The most common presentation we had of abdominal swelling, followed by loss of appetite, and this translated to the most clinical, common clinical examination finding of an abdominal mass. And we also had a finding of pallor in most of our patients. So looking at the laterality, the left-sided tumors tend to be more dominant than the right-sided tumors. We had 6 patients, that is 6% of the population presenting with bilateral tumors, Wilms tumors, one of whom was actually a metachronous tumor that developed 3 months after the discovery of the first side of the tumor. We also had one case, a particular case of a Wilms tumor in one of the kidneys with the contralateral non-functional kidney. This we also managed as per the SIRE protocols for that. And looking at the stage of diagnosis, majority of our patients actually presented late, that is within the stage 3 and stage 4 of the tumor staging. However, we also had a good number in whom the data was actually not captured. This translated to intraop staging, still of the above, still more of the stage 3 than the other stage 1 and stage 2s. For the histological patterns, when we followed up the histologies, majority of our patients actually had favorable histologies. But I just want us to look at the gray area. That was a good number of those that we did not actually find the histological results. So this is something for us to work upon. For the treatment modalities, we at KNH offer surgery and chemotherapy. We do the neoadjuvant and then the adjuvant therapy after the surgery. And of the surgical options that is commonly offered, we do radical nephrectomy, which contributes about 86.6% of the surgery that we do. However, we also had nephron sparing surgeries and partial resection in some of our clients. Of note, 3 of our clients we did not operate. Unfortunately, they died before we could actually offer any form of surgery. And looking at now the outcomes, for the immediate complications, we didn't actually have any. A good number of our patients, 92.9% of our clients don't have immediate postoperative complications based on those. But we had 3 who had bile obstructions, that is 2 had postoperative intussusceptions and 1 had adhesive small bile obstruction. In the long term, we looked at 6 months, 1 year and 3 years from the surgery date. We had majority of them tend to do well, that is 77, 59 and 27 clients still on follow-up up to the 3rd year, which translated to about 61% who are still stable on follow-up. But we also had a good number, that is up to 29.5% who were lost to follow-up by the 3rd year. For the mortalities, these were patients that were able to capture, but you remember there's a good number who are lost to follow-up that we really don't know about. For the relapses and the recurrences, mainly we saw them in those who had had debulking surgeries, which were about 7.1% at 6 months and up to 1, that is in the 3rd year on follow-up. For the sacrococcygeal, which was the most common of the tumors, a majority of our babies presented with sacral or gluteal swelling, that is in 82.6%, and they mostly presented within the neonatal period, that is less than a month. And we had, of all these that had presented during the neonatal period, we only had 1 who had a prenatal diagnosis, that is based on the antenatal imaging. It tended to be more common in the females than the males, with a ratio of about 1 to 2. For the management, it was mainly surgical. We had complete resection and coccygectomy in 73.9% of our patients. In 2 of them, we actually didn't manage to also operate, mainly because they died before we could actually offer. Then the challenge comes with the use of the surgical drains. Majority of our patients, actually, we don't routinely use the surgical drains after surgery. That is in 18 of them, 18 of 23. But 3 of them had surgical drains, mainly the corrugated drains. And one had to have a diverting stoma done on the third post-op day, mainly to control the sepsis. And in our setup, we also noticed 16 of the clients, that is, had benign mature teratoma with only 2 with the immature type. Looking at the outcomes for now the sacrococcygeals, immediate postoperative period, we have a lot of them getting surgical site infections, with about 4 of them, that is 18.2% having preoperative tumor ruptures. And these postoperative sepsis tended to influence a lot the postoperative length of stay, with most of our patients having about 2 to 3 weeks within the facility before discharge. We also noticed that there was no difference between the SSI rates in whether you had a drain used or you didn't have any drain used, or whether you had like a preoperative tumor rupture or not postoperatively. So for the discussion, the finding of the predominance of nephroblastoma in our setup has actually been a finding that was comparable to studies previously done still at the same facility. That is by Mwanda et al. In a study in 1999 and Mwika and Mutua in 2020. Studies which showed nephroblastoma to be second, that is at 14 and 16.9% respectively, to Burkitt's lymphoma, that is for the Mwanda study, and retinoblastoma for the Mutua and Mwika studies. But remember, we don't, lymphomas and the retinoblastomas are actually out of the purview of the pediatric surgery. So we referred to nephroblastoma as the most common in our setup. Abdominal swelling being the most predominant of the symptoms was also highlighted in a previous study still done at Kenyatta National Hospital by Onyango et al., in which he noticed a majority of the solid tumors in our setup tended to present with that. And in the late 80s, we had a study done by Jumbi et al., still on Wilms tumor, in which he found similar findings to our setup, the one of age being predominantly less than 4 years, the sex being predominant among the males, and then the left-sided being more predominant than the right-sided tumors. Looking at the diagnostics for Wilms tumor, we adopted the SIRE protocol mainly because most of our clients, based on previous studies, tended to present late. That is in studies done by Abdallah et al. In KNH and Njuguna in Western Kenya in our setup. For the sacrococcygeals, following imaging studies, that is ultrasound and CT scan, we noticed majority of our patients actually presented in stage 2 or stage 1. That is about 6 out of the 23. But we had 10 in whom this stage is actually not captured at the stage of diagnosis. Surgery is the mainstay of treatment, as already highlighted. Also in our setup, we found that, just to reiterate, 78.6% of our patients are stable on follow-up at 6 months, but this number dwindles to about 61.4%, that is by the end of the 3rd year. And those lost to follow-up, we have 10.2 at 6 months and 29.5 at 3 years. The findings above we thought were comparable to a previous study done in 2013 by Axt et al., in which we found that 2-year event-free survival to be 52.7% and loss to follow-up of up to 50%. For the sacrococcygeal, we have a good number up to 1 month, 3 of them being only present at 1 month of follow-up. So therefore, we have noticed that it's now impossible. We can't be able to assess actually the long-term complications of recurrence and malignant transformation, especially following management for sacrococcygeals. So in conclusion, most of the surgical tumors are actually manageable, as demonstrated in the previous studies, but multidisciplinary teams are actually indispensable to make a difference, and timely diagnosis and completeness of treatment with standardized follow-up protocols will make all the difference. These are some of my references. Thank you so much.